Good morning. It's such an honor being here with you. I was asked to speak on right treatment, right time, treating seizure patterns on the clock. Very complex. Each one has its own meaning. But after we discussed it, it was decided that I would actually follow on with Scott with some practical applicability. Disclosure unrelated. I wanted to give you a case, and each individual with LGS, whether child or adult, is different. But I wanted to give a case of resilience of not only the child, but extreme resilience of the parent and family through the course of never giving up. Great individual, actually now 27. First time I presented the case was 19. And as a pediatric epileptologist, I still follow the child through his mother. 19 years old, started having seizures at 5 years of age. Initially, pregnancy, everything was fine, and then everything hit at once. Speech problems, developmental problems, everything that you've heard about leading up to the diagnosis of LGS. But throughout the course of years, the complexity was the poor socialization, less friends over time, did not want to hang out with others, had difficulty with change, the sleep, family members sleep deprived, extremely important, because you need to take care of that individual with LGS. And if you're sleep deprived and having difficulty, that's a problem also. Appetite, weight loss, constipation. The parents traveled frequently to seek care because of what was heard earlier. They didn't get appropriate care. And then you have all the clinical issues. If your child is seizing, regardless of how many children that caretaker take care of, 24 hours is not a good time for callback, not with the frequent seizures. And you know this better than I. So lots of questions. What seizure type did the patient have? LGS, what's the diagnosis? What's the underlying cause? What are the comorbidities? Because that ties into management. What does a negative genetic study mean? Which study? What does any of this have to do with the medication given? When do you consider non-medical management? All of which is a part of management. So we heard of all the different seizure types alluded to, and the descriptions may be difficult, but if your child is falling to the ground and having injuries, you go into the provider and they tell you, what is it? Is it the drop or atonic? Is it the stiffening or fall? Is it the jerking or fall? For you, and should be for all the providers, the problem is the end game. You need to improve quality of life. Again, is that spark, as Tracy has suggested. How do we find that initial spark, and where do we go with that? And what does unknown mean? Does unknown mean stop? No, unknown means you have more work to do. We have more work to do. Because as suggested, LGS is the syndrome, but there are underlying causes for that syndrome. Even earlier, infantile spasms or West syndrome is the syndrome, but the underlying causes for that syndrome. These are some of the causes, but in the individual I saw, in the young man I saw some cues that suggested there may have been some features that may have been missed. And no blame game here, because we have to reevaluate every few years to determine even what we may have missed. Or there's absolutely no reason I can't reach out to Scott and say, these are the things I'm thinking of. Or a family coming in and saying, guess what I found? in this journal, or this is what my family colleague told me. Have you looked into this? You have to be open for that discussion. You also have to be open, in my mind, for the discussion of the so-called comorbidities. So, why are you treating with this medication if? And that if is a discussion that we should always have. Because it's not only the seizure type, not only the syndrome, not only the underlying cause of that syndrome, but what else? What are the other comorbidities? Is it the weight loss, weight gain? Do they have a superimposed diabetes? Is the cholesterol high? Should they really be on that diet or not? What of the GI symptoms? The cardiac? Skeletal? Don't forget that. Medications, bone loss, headaches. How do we tell? Sometimes we have to assume by difference in how the child, adult reacts that something else is going on. We have to be quite open, and we have to lower that pyramid and listen to everyone. It has to be this group of us, the team, not the neurologist, not the social worker, the team, including you, with you primary and or patient primary, that makes that decision. We just saw this. We discussed what possible medications could be used. But we also have to discuss unique features because of that baseline condition, and what medications should possibly not be used in certain instances. These are the so-called checky boxes that people put in place that should not be. It should be a discussion of what's going on with the individual who happen to have Lennox-Gastaut syndrome. We speak about time to treatment. After 1 to 2 medications, I suggest 1, and I know Dr. Perry suggests 1. If 1 isn't working effectively and you're moving on to a second, you have to second guess and say, am I doing the right thing? Is this the right medication? And you have to consider other modes of management early. When I say you, I don't mean you alone, but sometimes our target audience may need to be different. Our target audience now quite often are the epileptologists, but there are less than 2,500 of us that are actually being active. So we have to look at these extensions of care, whether it be neurologists, pediatricians, internists, nurse practitioners, community nurses. People need to be more knowledgeable about what's going on. If we diagnose earlier, how much of an impact can we have? How well does a medication work and change not just one thing, but everything? How well does the vagus nerve stimulator, for instance, or deep brain stimulator or others work? Do they only work for the seizures, or do you see such a significant improvement in behavior that if it works a little bit for the seizures, it may be worth putting back in, because you're looking at quality of life, and that is the end game. This workup, this milieu of what we call a phase 1, phase 2, and the medical jargon, I wanted to walk through because these are terminologies that you'd hear. So the so-called phase 1 is trying to identify that reason. And in epilepsy surgery, it's trying to identify what's the ultimate goal of the type of procedure: surgery, diet, other medication. When you hear of phase 2 in epilepsy surgery, is actually when we put these small areas in the brain that are being targeted with a hypothesis of where things are, or sometimes on the surface of the brain, to identify 3 things: where the seizures may be coming from, where the seizures may not be coming from, and where function is. And then the phase 3 is the more definitive procedure. I would suggest that within that phase 3, apart from the different types of surgeries, we have to look at all non-medical management and targeted approaches. So when should non-medical management or surgical procedures be identified? Well, I suggest it depends, because with some targeted precision medicines now, if you haven't used any of those, you should still consider it after 2 medications. But in some instances, you should start considering it after the first medicine. If you know there's an approach that you can get to improve the person's quality of life over time, you'll hear a lot more about this. So I won't go into depth, but I know the persons here that will be speaking about surgery will tell you the same thing. And each individual is different. So you focus on that targeted approach. You focus on trying to find that kindle that initiates the fire. And every time you initiate a treatment, sometimes it may modify that. And you may reduce that spread and allow all the rest of the forest to function well. Yeah. So in this young man, mom never gave up. She kept pushing and pushing. And we finally found this kindle, and we started scrutinizing on the imaging where this kindle may be. And by scrutinizing the imaging where this kindle may be, we identified an area deep to where language was that we could ablate. But that wasn't the end game. Mom, like everyone else, and myself said, you know what, with all these complications, let's start reducing some medicines. And the seizures came back. And I was a bit despondent. I said, you know, we can't touch language. And mom said, no, you can't give up now. It's been years. We got to keep pushing. So we looked again, and we identified the area close by, and we went back and did this, and we reduced the seizures. And when we reduced it some more, mom said, my concern now is we're having some events at night. And earlier, we had had the discussion, as we should, about sudden unexpected death in epilepsy. She said, how about the circadian rhythm? How about if we change the time we give the medicines and give more during the evening to reduce the number of seizures at night? And we did that, and sure enough, he's doing fantastic now. I spoke to her 2 days ago. He's had very few, if any, events in the last 3 years. He's transitioned, which is important, to an adult colleague, and myself and the adult colleague speak often, but even more so, me and this mom and dad that taught me so much in my course have actually engaged frequently. Because we speak about the syndrome and the seizures, but it takes everything, the clinical care. It takes the research, translational, clinical. It takes engagement with the community, be it teachers driving the workforce. It takes advocacy. It takes the LGS syndrome. It takes addressing the stigma associated, the management associated, getting to the areas that I need, and determining what's your end game and who is your target audience. Because the target audience should be all of those taking care of your children and adults with Lennox-Gastaut. It should not just be the epileptologist and you engaging. It needs to be that comprehensive care, the social worker, et cetera, that I have learned from many of you and persons with LGS. That's important, that's needed as we move forward. I'd like to thank you again, and I'll see many of you in the workshop, I'm sure. Thanks.